let's start. Let's start with the main character. Again, I'm now forgetting the psychologist who realizes anyway the ending it feels wrong.
Malcolm? No, and spoilers ahead. Everybody's seen the film,
Yeah.
so
Okay.
and anybody listening at home or watching this recording that has not seen The Sixth Sense, you've got 2 seconds to turn this
log
off.
off right now.
So this is Malcolm Crowe. All right, what do you
Yeah,
got?
Malcolm, who believes at the end that he is dead, and so I think like always the first thing that comes up are delusion. About, like, believing.
Yeah, I mean, if there were a sequel to this and it starred Bruce Willis, I think the Cotard delusion is probably where we're going to start, right? So the Cotard delusion can be experienced in a vacuum. So it can be a single best answer on a shelf exam, Cotard delusion. Although it could also be seen in the context of a larger disorder. And that would certainly, I think, at the top of the list include schizophrenia spectrum and other psychotic disorders, as well as even the depressive disorders or mood disorders that would include bipolar, right? I think those are your primary, two primary, the differential. For this particular character, in terms of what you've seen in this movie, are you feeling psychotic versus mood? Psychotic? Yep. So there's an absence of mood symptoms, and psychotic would be the diagnosis of exclusion here, meaning that if there's any evidence of mood symptoms, it's mood, and if not, then psychotic. So we're thinking psychotic. Do we think the Cotard delusion is part of a larger illness within the psychotic disorders chapter? So schizophrenia or other psychotic disorders?
My thing is, I feel like there is some mood issue to address, but if we're looking at psychotic disorders, schizophrenia probably looks more like, right, following a stressful event, right?
Why we just going back to your original comment, your initial comment, why do you feel that there might be mood symptoms in The Sixth Sense?
He just kind of like refers a lot to like feeling family, his relationships, and feeling just kind of like losing time, kind of morose, looks depressed.
So if we're not comfortable definitively ruling that out, maybe it's the Cotard delusion, say that quickly, in the context of a primary depressive disorder, something to consider here.
Versus also like the delusions.
Yeah, so maybe it's more diverse, and if that is the case, and we're looking at this through the lens of a delusional disorder, with the Cotard delusion being unspecified type, maybe there's additional themes that are part of this complex. What would be delusional belief that his patients can speak to? That maybe it's grandiose. Is that a gift? Well, I think that's I think a trope of the film. Is it a gift, right?
I can see it being grandiose in terms of like also feeling like a child, right?
Mhm.
You have to be the one, like,
Remember, for purposes of the shelf exam, there are different themes or subtypes of delusional disorder. JPEG, so jealousy type, and then persecutory, erotomatic, grandiose, and somatic. So maybe this is grandiose. And there's a scene at the beginning of this movie prior to the gunshot where he's speaking about himself through the award, and there's a brief scene where he's seeing his reflection in the award, and it's a nice little I think tip of the cap to what fictional character, what mythological character. Yeah, Narcissus. Yeah. So there's maybe an element of narcissism here or grandiosity.
There's a lot of jealousy too. I think with this spouse, like, I mean, we're kind of led to believe that maybe she is cheating, but even if she's not, he like seems to believe that she is. He seems to believe that.
So delusional disorder, mixed type. Okay. And that would be jealous as well as grandiose, and it specifies specifically the Cotard delusion. Okay. All may, in fact, be in the context of a larger mood disorder. Yeah. Depends if we think the gunshots are going. I think
Sure.
it might be. Other thoughts about Malcolm Crowe? What would you need to see in this film? What would M. Night Shyamalan have had to include in this film to actually work up this particular character's grandiosity and rule in for narcissistic personality disorder? So, starting simply in terms of what you're going to be specifically looking for in the case vignette is evidence for arrogance and haughty behavior, and the belief that, in this case, Malcolm is special and can only be understood by someone as special as he is. And then the diagnostic criteria just kind of support that cardinal feature. That's what you're looking for here.
In that context, would the child be rejection? A lot of like parents or like their children, them, right? Or that was happening. Cool.
Especially his performance in the play,
Right. Yeah.
who's really being carried off the stage there. All right. Any other characters here? Cole. All right, so Cole presents to you with the chief complaint of the dead people. What are we thinking here? Let's get this out of the way because it's something that Malcolm Crowe actually says. Childhood schizophrenia. Bump that. Sixth Sense is not about childhood schizophrenia. Give you that. What is it about? With the disclaimer here that no one is a child psychiatrist.
The dead people imaginary.
I think it started out to be normal behavior. That people are imaginary friends. Would be age appropriate. The question is qualitatively, is there anything going on that would lead us to believe that we probably should do more investigating or reassure that this is?
I think what they were most concerned about was the self-harm
Mhm.
or the scratches on him.
There's more work to do. Now, Malcolm specifically says that A, look like defensive wounds, and B, don't think it's the mother. So, and I have to look closer. I'm not really sure that they aren't self-inflicted. Again, I think we should think that they're self-inflicted.
It looked self-inflicted, but it should. It is across the line.
And there's the one on the back though.
That's true. The one on the back towards the end.
And again, we couldn't rule out both either, but I would think that self-inflicted wounds would actually be forearms, where those that would be defensive wounds would be on there. I have to take a closer look to see if it's either or both. In the back, So he lives with the mom. Malcolm could say that he doesn't think it's the mother, but Child Protective Services is involved nonetheless. Any other thoughts here? Let's say there are self-inflicted. Safety first. We want to make sure that this is not a mood disorder or in any other way self-inflicted wounds that would have suicide attacks. Let's say we've investigated and that does not appear to be the case. What's our differential diagnosis for self-harm? Case non-suicidal self-harm. Yeah, so that's a concern here. And if whether or not we actually provide that diagnostic label, especially at this young age, what is the process? What is the actual mechanism for which this would happen?
not having. I mean, the relationship between the child and the son is fine, but you know, mom to tell him. He has some issues when the dad left. Unstable.
But this is a referral for psychotherapy. Get therapist.
Family therapy.
Okay. What else? What's the actual neurobiology of non-suicidal self-harm? We'll start there.
Wasn't it like to get pain? Or they on themselves?
Okay, so individuals who do this, characteristically, I mean, nothing's ever a perfect given. Characteristically, will often say that they feel numb. That's part of the numbing criteria of post-traumatic stress disorder. They feel numb. They feel detached. And by cutting, it resolves those feelings. Those feelings become intolerable. Individual may cut. Form of maladaptive ground. Mechanism of the dissociation is likely opioid mediated, looking at the mu receptor. And as an attempt to, maybe this is through psychotherapy, adopt more adaptive strategies. Therapists can actually partner with prescribers to provide what medication that would block the mu opioid receptor, help stop that numbness so that the individual does not resort to these maladaptive grounding techniques. Yeah, and it actually goes by the brand name of Revia. So that's a consideration on your shelf exam. So again, the general idea is that during the time of trauma, the individual, in regard to hypothalamic function, dissociated, freeze, right? Fight, flight, freeze. Option for cold was freeze. And while potentially life-preserving at that young of an age, soon thereafter, older childhood, teen, adult, those same feelings reoccur, re-experienced, and now become not adaptive, but are now maladaptive. They actually aren't independent. Themselves resulting in clinically significant distress or functional impairment, and now you have to provide biopsychosocial management, which can include a medication like Revia. What else would call anything else?
I think the only other differential is like child self-harm is not like the like ASD. Sometimes you see in that context.
Good point. Yeah. All right. What are the characters? In both of the.
Oh no, so this is like kind of a side quest, but the wife. So we know from the timeline at least a year. So assuming we're at the 12-month point, we could say she had auditory.
Yeah, yeah, and evidently at some point, off screen, she was evaluated because she's had an SSRI. So the clinician, the prescriber, appears to have actually diagnosed a major depressive episode. You usually don't prescribe SSRIs or medication as general antidepressants for that treatment as well.
To be fair, at that time there wasn't a physical diagnosis. But yeah, it does seem like she met criteria for MDD according to that.
And there, again, maybe it's because we didn't want to make this come 2.5 hours, but there's no psychotherapy involved either, so it jumps right to meds. There'll be some problems with the script. But that could explain a lot. Somebody list for me the different disorders within the depressive disorder chapter of the DSM other than major depressive disorder. Okay, so which is what? 2 years, right? 2 years and never more than 2 months without symptoms. Otherwise, it really is sticky caps. It's basically the same. There's a little bit of tweak, but I don't think anything that's going to come up in an exam, one way or the other. For all intents and purposes, the city caps more chronic operationalized in terms of the APA here is 2 years, never without symptoms, or 2 or more months. And not because you're going to need to know this, but you only required 2 from the symptom set, not 5. Rule of 2s. All right, what other depressive disorders are in this chapter? Right. Premenstrual dysphoric disorder, which is not a mental disorder. A depressive disorder due to an underlying condition. A medical condition, but it's an underlying physiologic condition. Which is what? Somebody explain to me the onset and offset of PMDD.
Starts before the onset of menses and then improves, like within a few days afterwards.
Why?
Like when all of the hormones in like after the luteal phase are decreasing, they'll experience the dysphoric symptoms, and then once menses starts and they begin to
Backwards. What's the culprit here? More specific. Progesterone is at its peak the week prior to the menses.
and estrogen is at it.
Progesterone is thought to be the culprit here, and symptoms improve within 1 week following menses because progesterone drops. So you're asked the physiology behind this, and this is why it's not a true mental disorder. It's quote unquote hormonal. It's a depressive disorder due to an underlying condition, physiologic condition. That condition really is hallmarked by progesterone. It's peak and it's trough. That's premenstrual dysphoric disorder. Any others?
Mhm.
All right, I'll give you seasonal affective, and that's going to allow us to segue. So, what is seasonal affective disorder?
Episodes during more than
Right. The APA says you have to establish a pattern. Not everyone, I mean, it's a 1 in 4 chance that you're going to have your onset of symptoms during, actually it's 50-50, it's either fall or winter. So as not to just confuse a coin flip with this condition, you have to have 2 recurrent. You call it a pattern. And then the symptoms resolve during the spring or summer. Seasonal affective disorder. Now that's a WHO diagnosis, which means that it's not likely to appear on your shelf exam. What is the APA moniker or label for this? And that segues right to the different subtypes of depression. So what are the different subtypes of depression? Features. What are atypical features?
mood reactivity.
I think we're missing one. Yeah, I think you did that. I'm trying to think. What are? Yeah, rejection sensitivity. But I mean, there's no way you miss that in shelf exam. Literally all of them don't. Any other subtypes? The answer is yes, actually. What are the other subtypes?
I don't know if this counts, but like pseudo dementia.
We'll talk about that in a second. So the acronym is,
Postpartum, right?
that's usually an onset specifier, but we'll actually allow it. So it's a little different. It's not considered a subtype. It's really considered to be an onset specifier where the individual has the onset of symptoms during or after delivery. So 50% actually occur prior to delivery. So peripartum is the adopted terminology as of 2013. So
What makes you so stressed?
Anxious distress, good. Catatonic subtype. The other one is melancholic. And the final one is mixed features. Individuals have aspects of mania, but don't reach full criteria of a manic episode. Of course, if they did, it's bipolar. The acronym is CAMPS. There are 2 A's and 2 M's, so you can kind of keep this together. And the 2 A's are atypical and anxious features. The 2 M's are melancholic or melancholy and mixed. Subtypes. What is pseudodementia? It's not a subtype.
Well, and it might appear at first that they have dementia, but really they have. You can tell them beyond that. You're doing your cognitive assessment. Maybe they'll perform poorly at first, but when you redirect them, they actually can do it. And you can maybe differentiate it from true dementia by the presence of the depressive features being the main symptom that they're presenting.
And in times which tend to be frequent where that is not possible, geriatric depression scales or objective measures are used. And then, quite frankly, in a clinical setting, what is often done is a trial of an antidepressant to see if the quote-unquote cognitive deficits improve with, for instance, SSRI therapy. That'll, of course, clinch the diagnosis. But again, the true appreciation, and we're going to segue right back to the original question with this, is that depression does not present in everyone similarly. And the first thing I want everybody to think about is the very young and the very old. The very old, SIGI CAPS is much, much more likely to present as dementia. So, and when it is, when we find that the individual who's presenting with cognitive deficits actually has major depressive disorder, we call that pseudodementia. It's depression that is presenting with cognitive deficits instead of or in lieu of SIGI CAPS. Very young, very similar, right? Behavioral, right? Maybe plus or minus somatic, cold, right? So the very young and the very old. And focusing on the very young, there's another condition that is in the mood disorder chapter that is specifically focused and created for a younger population so as to alleviate or avoid the misdiagnosis and overdiagnosis of bipolar disorder. What is that? Disruptive mood dysregulation disorder.
EMD.
That's the, I think that might be the final illness in the chapter, getting back to our original question. And it's pretty much what it sounds like in terms of disruptive mood, dysregulated mood. And the primary focus of the APA creating this new diagnosis as of 2013, as of the DSM-5, was to lower the incidence and misdiagnosis of bipolar in children. Somebody correct me if I missed anything. Are there any other conditions, disorders in this depressive disorder chapter that we may address? I think we're good. Getting back to the film, anything else catch your eye here to discuss?
Character with fictitious by other.
Yeah. Right. So this is certainly the major turning point in the film. This is factitious disorder imposed on another, previously known, and please follow me here. Factitious disorder by proxy, itself previously known as Munchausen's by proxy. Right. So I would love to tell you that we're only going to use that as the shelf exam is only going to have the most updated terminology, but I'm not so sure. Right. So just know that Munchausen's and factitious are the same thing. There are articles, theorists that believe that that's not exactly the case, that Munchausen's is a variant, therefore more severe form of factitious. Don't buy it. It's not going to show up on the shelf. Right. So it's only important if it shows up on the shelf. So for you, factitious equal Munchausen's, and this is factitious imposed on another versus if it were imposed on oneself. How do we know that the mom here is not malingering? The answer is because there's no evidence of external pain written. If I don't want to mention any film because it's an instant spoiler, even though it's an awesome film. Oh, myself. If M. Night had written in just another line or two into the script about what funds the family was receiving from a GoFundMe page, stories changed. Okay, but without that evidence, the default is always fictitious. We always assume that it is internally or unconsciously motivated until proven otherwise. And then as soon as we're proven otherwise, we switch to diagnosis. We expand the diagnosis to include malingering. In this case, malingering imposed on another, which isn't a thing, right? It's a crime. So the criminal justice system will be involved in that. Right. Now, if you really want to get to know the mom's motivation, which again is unconscious to her, watch that scene when Cole and his pro walk into the repast. Put on your closed caption so you can actually see what people are talking about, and you can get your instant motivation as to what's guiding this mom's behavior, but she's unconscious to it. I'm not going to give anything else away, so you're going to watch this again. Right, this is factitious, and specifically factitious imposed on another. In both factitious and malingering, there is lie and there is deceit. Individuals are misrepresenting their symptoms, or in this case, creating and misrepresenting symptoms by proxy or imposing them on another. That's true for both malingering and factitious. What separates the two, what differentiates the two, the motivation content. The motivation is internal or unconscious, we call it factitious. But as soon as we see an external motivating factor, a GoFundMe page, we switch the diagnosis to malingering. How does any of this differ from somatic symptom disorder?
Somatic symptom disorder, they're not aware of anything that they want to be, also unaware of the reason. What they're like presenting for.
That's right. And as such, there is no deceit. That's the main thing here. There is no misrepresentation. They are representing themselves accurately, even though what they are representing, what they're presenting with, is not congruent with an underlying medical condition. So if you're all diagnostic testing, you're at a loss as to what is causing the patient's presenting. If those presenting symptoms are voluntary motor and or sensory function, we call it conversion. If they're anything else, we call it somatic symptoms. So think of conversion disorder as a variant of or a subtype of somatic symptom disorder. And somatic symptoms focus on voluntary motor or sensory function. Any questions about the mom here? Any other thoughts, scenes, or characters you'd like to discuss?
Related to the mom. First scene where Cole seems to be aware that he's in the room, right? So there's like this weird idea of like what is reality. Only Cole can see Malcolm, and Malcolm's wife can't see him, right? Because from that point forward, it's like his Malcolm. I don't know if this is more just like a loophole. Is the mom also sort of like believing in this initial delusion that goes to two? This is sort of like
What made you think she can see?
because of the initial interaction where they're waiting. And
They're not talking.
They aren't talking, but
They're
she
making eye
says
contact.
somebody's here for you, right? Like she doesn't. I thought she said the doctor's here for you. All right.
We need to check that though. That's major.
Yeah.
That's a big blooper. If that's true.
Well, yeah, I was trying to think back, so it's like the whole time he needs to be a ghost, right? So what part of it is reality and what part of it is not? Yeah,
Again, I think Cole's mom's also depressed.
Yeah.
This one, I think, would be persisting depressive disorder because we find out. So we kind of get the hint with the movie, but we certainly find out at the end of this film. It has a lot to do with the death of her own mom. Okay. So this movie really does shape up as an extra review. Whether it's major depression or whether it's persisting depressive disorder, and that's hopefully women characters. And then you could also discuss it in the context of whole and what extent is the Cotard delusion wrapped up in a larger condition that also be a disorder. Other folks here? Other questions about anything we cover in terms of the mood disorders, traumatic symptom related disorders? All right, we'll leave it here. I will be posting sometime, so we'll talk about this soon, about what the next Friday's films will be.